Introducing fresh hot grills. The goodness of fresh veggies, real cheese, and a buttery crust.
Okay, very good evening, dear students. So, I am Dr. Dharmendra Singh, your psychiatry faculty in PW MedEd. As we decided, we are providing this FMG spotlight. Today, I will take psychiatry. Exam is on 20th January, and as you know that always I discuss that minor subject have a very big impact on these exams, particularly yes FMG, or whether you talk about the any PG exams, usually 50-60 MCQs they are asking from these minor subjects, and psychiatry more and more MCQs they are asking. So today, without wasting time, we'll cover. I'll cover the MCQs, previous year's MCQ, and simultaneously I'll tell you what are the important points they are going to ask. Because in Indian exams, there's a rule of these exams that they don't change the topic; they just change the MCQs. So in between, I'll request that any queries you have, please message on chat box, and I'll try to revert as soon as possible. Usually we ignore psychiatry as a subject in MBBS, and that's later on we pay for it, because the psychiatry was, yes, it was a ignored branch before, but gradually more in a it is more in a spotlight in exams, also in otherwise also in medical fraternity. So more and more focus on these new areas nowadays. The examiner are they are keen to. Usually there are particular areas again and again they are asking, so today we'll discuss about them. And just if you remember even those points, it will be, I assure you that it will be very useful for your exam, the coming exam on 20th January. So first of all, happy new year, I wish you all the best, and I think everything will be fine. In 2024 you will succeed, and everything will be. But yeah, currently, yes, you should not think about the result, what result will happen. Still you have 10-12 days. So now you can't study or the read new things, but yes, you have to make a good plan about the revision. And I think this, the way we are, the our PW app, our platform is providing, I think it will be very useful for you, that all subjects you will able to cover in 2 hours time span. If we'll go for the first MCQ, a 35-year-old person with symptoms of sadness and feeling of loneliness was diagnosed with depression. He's prescribed medication which is a serotonin norepinephrine reuptake inhibitor. Identify the drug. The options are fluoxetine, venlafaxine, phenelzine, and the citalopram. So you know that first you should know we have SNRI. SNRI is SNRI, serotonin norepinephrine reuptake inhibitor. We have venlafaxine, we have desvenlafaxine, and we have duloxetine. Duloxetine. So number one, the answer in this MCQ will be B for Bombay. Uh, Quickly, what important thing they can ask about the venlafaxine? You should know it's we usually venlafaxine we use in severe depression. We use in severe depression. Usually, clinically, the theoretically speaking, the pharma says that all antidepressants having a equal efficacy, but clinically speaking, that SNRI is a better drug for the severe depression, because they target not only serotonin, they also target the norepinephrine. Desvenlafaxine and duloxetine. Duloxetine, you know, they sometimes they ask this MCQ that duloxetine basically, apart from as an antidepressant, we use in a diabetic neuropathy. Diabetic neuropathy, and usually we use in a somatic symptoms. This will be very difficult MCQ, somatic symptom wala, but you should remember. But yes, diabetic neuropathy they can ask. So various neuropathy, including the diabetic neuropathy, duloxetine we use. Antidepressant is a very important area. Again and again they ask. So what other MCQ they can ask in this area? That one is SSRI. You know that the escitalopram, citalopram, sertraline, fluoxetine, fluoxamine, SSRI. Usually SSRI they ask the side effect, that erectile dysfunction and the delayed ejaculation. Delayed ejaculation we use as a effect in a treatment of premature ejaculation. Yeah, very good evening. Very good evening. Okay. Yeah. Now it's clear. Okay. Okay, Prem Prakash. Yeah. I'm not late. I think it's a by 8 days. No, it's my session was on Monday only today. So other antidepressant, what they can ask, the one MCQ they ask about the bupropion. Bupropion, please remember, bupropion is a NDRI, norepinephrine dopamine reuptake inhibitor. So in NDRI, basically it's a sexually safe, least sexual dysfunction. Least sexual dysfunction. Bupropion causes the least sexual dysfunction. Apart from that, yes, it is contraindicated in epilepsy. It is contraindicated in epilepsy. Okay, and it has a least switch. If the patient having a depression, it has a least chance of switch into the manic episode. One MCQ also they again and again they are asking. So just I'll tell you the quickly, and it's a very important area if they ask, so don't get confused. If they ask about the erectile dysfunction that related to antidepressant, erectile dysfunction, the maximum chance is tricyclic antidepressant, then the SSRI. Okay, then the venlafaxine, then the mirtazapine, and then we have the bupropion. So if they ask maximum, then it is in a ascending order: TCA, SSRI, venlafaxine, mirtazapine, and bupropion. If they ask the least chance, then the bupropion has a least chance, and the maximum chance is with TCA. So whichever way they ask, you can answer. Okay. One more MCQ. Recently they asked about the TCA. That TCA toxicity they are usually asking. In TCA toxicity, we basically TCA toxicity, the options were it causes the arrhythmia, it causes the confusion, it causes hyperthermia, but the option was given hypothermia. So hypothermia was not the answer. So basically TCA toxicity causes the hyperthermia, the confusion, the arrhythmia, ACG related, the side effects, right axis deviation. The MCQ they are asking. Treatment of TCA toxicity is what? Sodium bicarbonate. We use the sodium bicarbonate, that you have to remember. So in this, the first MCQ answer was the venlafaxine, B for Bombay. Okay, the second MCQ, the 34-year-old mother was diagnosed with mild depression. She has a 3-month-old child. Which among the following should be preferred? Cognitive therapy plus antidepressant alone, and electroconvulsive therapy. So please remember, in MCQ, read carefully. It's a mild depression and the 3-month-old child is there. So the examiner giving the hint that 3-month-old child is there. There is a issue of breastfeeding because mother is doing the breastfeeding to the child. So what to how to avoid the side effect due to pharmacological intervention. So if the mild depression is there, if the mother is having a breastfeeding, symptom severity is not very high, then you can go directly for the cognitive therapy, or we can say the cognitive behavior therapy, CBT, without antidepressant. Okay, so in mild depression, in a during breastfeeding, mother can you know we can give only cognitive therapy. So answer will be A for apple. Okay, so this type of MCQ, they ask, if they ask the in during pregnancy or the during breastfeeding, which antidepressant is the safest antidepressant, then your answer will be sertraline. Your answer will be sertraline is the safest antidepressant during pregnancy and after delivery during breastfeeding. Sertraline is the safest antidepressant. Okay, about electroconvulsive therapy, yes, please remember the ECT is the safest procedure during pregnancy. So if the patient having a usually we think that in pregnancy, whether we should give the electroconvulsive therapy or not. Please remember, ECT, the third trimester, you have to be little careful. Otherwise, medication, yes, we don't have a sufficient data to prove that whether this medicine will cause the side effect or not. Whatever the data we have, we don't have a legally nobody will permit us to, ethically nobody will permit us to do the study on a pregnant lady. So whatever the data we have, these data are unfortunate, like somebody had a unplanned pregnancy and then had a side effect. So from there we come to know that okay, these are the side effects due to these drugs, but actually we don't have a good sufficient data. So usually we say the risk and benefit ratio, but we can't say with the certainty that yes, this drug will cause the side effect or this drug not. But yes, electroconvulsive therapy is the safest procedure during pregnancy if they ask. Okay, so in this MCQ, answer will be cognitive therapy. Yes, very true. Yes, yes. So Santa, very right. QT prolongation, yes, Manish, QT prolongation, right axis deviation is there. QT, PR, QRS will be more than 100 millisecond, okay, in TCS toxicity. So that you have to remember. Immediately if the patient come to the emergency, immediately after TCA toxicity, we can use the gastric lavage, but otherwise we use the sodium bicarbonate, Manish. Okay. Okay, which among the following is not a, so this the next MCQ, which among the following is not a symptom of panic attack? Uh, please tell me, suicidal thought, sweating, palpitation, tremor. So can you give the answer, anybody, which is not a symptom of panic attack? Yes, guys. So the symptoms of panic attack are, we from top to bottom, if we'll talk about the, we have a the dryness of mouth, okay, the dryness of mouth, okay, we have the palpitation, we have a tremor, we have a sweating, we have a the bloating sensation, okay, bloating sensation, or we can say the diarrhea like feeling, or sometimes the even diarrhea. And we have a the giddiness. Yes, very true. Yes, Susanta, very true. Suicidal thought is basically not the so it will be the answer. It will be the answer. We have a dryness of mouth, we have a breath, the breathing difficulty, or we have a the choking sensation, okay, choking sensation. We have a uh, the patient will say, sir, I'm not able to breathe properly, I think I will choke out. And the bloating sensation, the diarrhea like sensation, the restlessness, the sweating, patient will have a giddiness, patient will think that today is my last day, I'm going to die. So that's how the crescendo and decrescendo we have a in uh, panic attack is a sudden onset, it's a acute in onset, it gets peak reaches by 10 to 15 minutes, and then gradually decrescendo, anxiety subside and the energy got drained, patient feel like you know without energy at all. There is no energy. So this is a like typical presentation of panic attack. Whenever the panic attack comes, patient rush to the emergency, and usually they ask panic attack, panic disorder. Usually again and again this topic, dear students, they are asking. So what are the MCQ they can ask? One, they asking what are the symptoms of panic attack, except. Number two, they will ask the patient had a panic attack, patient rush to the emergency, what all investigations you would like to do. So what are all the investigations you would like to do, except uh, panic attack, that we have to rule out the medical cause of panic attack first. Okay, so what are the medical causes of panic attack? The medical causes of panic attack, we have number one, we can have arrhythmia. So we do the ECG, we do the blood sugar level. Okay, blood sugar level, because hypoglycemia can cause the panic attack. We do the EEG because epilepsy can cause the panic attack. Okay, this mitral valve prolapse. So again ECG, mitral valve prolapse can cause the panic attack. Okay, uh, thyroid profile, because hyperthyroidism both can cause the panic attack. So thyroid profile also we do. 24-hour catecholamine level we do, because pheochromocytoma. So these are the medical causes of panic attack. The hypoglycemia, the hyperthyroidism, the mitral valve prolapse, the pheochromocytoma. These are the some medical causes of panic attack. Usually whenever they give this all the options, one option they give what, hemoglobin or complete hemogram. Complete hemogram is nothing to do with the panic attack. So whenever the patient having a panic attack, we don't do the complete hemogram. So usually they ask the complete hemogram, and that will be the exception. Other the options they will give, they are the medical causes of panic attack. So number one, what are the symptoms? Second, they ask the medical causes of panic attack, and the third, they ask the what is the treatment of choice of panic disorder. So please remember, the treatment of choice of panic disorder is CBT, cognitive behavior therapy. Cognitive behavior therapy is a treatment of choice. If they ask the best modality of treatment, the best modality is CBT plus SSRI plus benzodiazepine. Okay, so CBT plus SSRI plus benzodiazepine is the best modality. So best modality is about combination of medicine plus the CBT. But if they ask this the treatment of choice, your answer always will be the CBT, cognitive behavior therapy. Okay, so these are the area they can ask in the panic disorder. Okay, the next MCQ, this is the direct MCQ. You should know which among the following deficiencies is responsible for cognitive impairment in old age. So the answer will be, anybody, what will be the answer? Vitamin C, vitamin B12, vitamin B6, vitamin B2. So fatafat, what will be the answer? Yes, so it will be, the answer will be vitamin. Yes, anybody? Answer will be the vitamin B12 deficiency. Vitamin B12 deficiency, yes. Okay, Manish, yes, very true. B for Bombay. This is a direct MCQ. In biochemistry, usually you study in detail that what are the other importance of other vitamins. But vitamin B12 is very important because it's a helpful in a myelination of nerve and everything. So it's a very important vitamin, and we can have a cognitive impairment. So usually in classes also, to my patients also, usually I say that if you are a vegetarian, it's fine, but you have to take the vitamin supplements, because vitamin B12 is the only vitamin which we have in a product of non-veg origin. So vitamin B12 is responsible for deficiency. Vitamin B12 deficiency is responsible for cognitive impairment. Okay, the next is that again and again they are asking, chronic alcoholic patient suddenly withdrew his alcohol consumption. Later he developed tremor, global confusion, ataxia, and other associated symptoms. Which among the following is the most appropriate management for the given patient? So first you should know that what is a the diagnosis of the patient. So patient having a one we call GOA, GOA. It's a mnemonic for the what? Wernicke's encephalopathy. It's a mnemonic for Wernicke's encephalopathy. Global confusion means what? It's a delirium. Global confusion means what? Delirium. O is what? Ophthalmoplasia, and A is what? Ataxia. Okay, ataxia. The ophthalmoplasia due to sixth nerve palsy, okay, sixth nerve, the abducens. Now it actually you know it basically supply the lateral rectus, so it's a bilateral rectus, bilateral lateral rectus palsy, and ataxia will be there. Yes, so in the diagnosis will be Wernicke's encephalopathy. These will be the symptom. Basically the treatment in Wernicke's encephalopathy, we use the IV thiamine. So please remember, even patient is not eating properly, there can be the hypoglycemia, but the rule in Wernicke's encephalopathy, first you have to push the around 1000 milligram IV thiamine. Yes, hello. Yeah, so once you okay, once you okay, so once you the IV thiamine, once you give the thiamine, thereafter, yes, the if there is a hypoglycemia, you can give the glucose, but the thiamine is the most important thing initially you have to give. If they ask you the what is the first symptom respond to the medication, the or first symptom respond to the treatment in a Wernicke's encephalopathy, it's a ataxia. Okay, ataxia. So it's a roughly the sorry, the first symptom respond to the medication, I'm really sorry, it's ophthalmoplasia. Okay, so the first symptom respond to the medication, it's ophthalmoplasia. Okay, yeah, even we treat the patient very nicely, but still the 50% patient, still 50% patient have residual ataxia. Okay, so the first symptom respond to the medication or respond to the treatment is ophthalmoplasia. Within hours, ophthalmoplasia responds to the treatment, and ataxia, even we treat this patient very sincerely, still 50% patient have residual ataxia. If these patient don't come on time to us, or if they even they come and we don't treat them seriously, then they can convert into Korsakoff psychosis. Okay, so Wernicke's encephalopathy is usually occur due to lesion in memory body and bilateral nucleus of thalamus. Okay, so a lesion in the memory body. Bilateral, lateral. Okay, so that you have to remember. So in this, answer will be B for Bombay IV thiamine. Okay. IV thiamine. Most common symptom of alcohol withdrawal. The most common symptom of alcohol withdrawal is the tremor. Tremor is the most common symptom of alcohol withdrawal. If they ask you the most common symptom, the answer will be tremor. If they ask you the most common syndrome, okay, okay, so the most common symptom is tremor. Okay, tremor. Apart from that, we have in alcohol withdrawal, we have a simple withdrawal symptom, and we have a complicated withdrawal symptom. Those MCQs will come later on, and will talk about it. Okay, so tremor is the most common alcohol withdrawal symptom. This MCQ will come again, so we will discuss in detail. A pregnant mother was given lithium. The child might born with which the characteristic anomaly. Lithium is the dear students, please remember, lithium is such an important drug. If the in paper the MCQ is not there about the lithium, then please the paper is going to cancel that kind. 100% one or two MCQ they will ask about the lithium. So please, yes, Manish, yeah, very true. So the answer will be the Epstein anomaly. We have the Epstein anomaly of the tricuspid valve. Answer will be C. So about lithium, what MCQ they can ask? Please remember one by one. Number one, they will ask lithium has a narrow therapeutic index. Okay, so any drug which has a narrow therapeutic index, we have to check the level. So we have to check the level of lithium, acute phase and prophylaxis phase. Okay, yeah, very true, Manish. So acute phase is the 0.6 to 1.2 millimole per liter or milli equivalent. Prophylaxis is 0.6 to 0.8 millimole per liter. Okay, millimole per liter. Number two, the common side effects of lithium is ataxia, memory deficit. Okay, the patient having a acne, psoriasis. Okay, these are the common side effect you can remember. The important thing they will ask that when you check the level of lithium after 12 hours of last dose, after 12 hours of last dose, suppose in night. So any medication, we one word we are using, steady state level. So what is the steady state level? Today you started the medication, because of half life, tomorrow the level will be low. Once the any drug achieve the steady state level, thereafter there is no fluctuation in a level of the medication. Okay, any medication achieve the steady state level only after 4 to 5 half life. Okay, so usually the lithium you started today, we usually check the serum lithium level only after 4 to 5 days, particularly the 5th day. If they ask you the 4th day, 5th day, 6th day, 7th day, your answer will be 5th day, because the once the drug achieve the steady state level, thereafter only we can check the level of that particular drug. The 5th day, and when you check, suppose you are giving morning 10 a.m, you give night the 10 p.m, so 5th day you will check the after 12 hours of, so in morning we'll check around 10 a.m before giving the medication, okay. This time recently they one very difficult MCQ they ask about the lithium. Usually see what happens, the during pregnancy, first trimester, second trimester, third trimester, basically we have to the plasma level, the due to physiological changes of pregnancy, the blood level or the plasma level is increases, and because of that you have to increase the level of lithium to maintain that level. Okay, and after delivery suddenly there is a level gets yeah. uh, Okay, lithium toxicity. Okay, Manish, I'll tell you. We'll talk about the lithium toxicity. Okay, so the I was talking about that during pregnancy, the physiological changes of pregnancy, and there is a increased level of the plasma level. So we have to increase the lithium level. After delivery, there is a sudden fall of the plasma level of the blood level. So we have to decrease the dose of lithium. So you have to see that in which trimester they are asking, what MCQ they have given. Accordingly, you have to answer. Okay, Manish, you are asking about the lithium toxicity. So lithium toxicity we'll talk about. Lithium toxicity, usually I mentioned that the acute level of serum lithium is 0.6 to 1.2. Lithium toxicity starts once the level is more than 1.5 millimole per liter. Okay, the lithium toxicity starts once the level is more than 1.5 millimole per liter, Manish. The clear cut toxicity when the level is more than 2 millimole per liter. Okay, so the toxicity starts after 1.5 and the clear cut toxicity is after 2. Okay, yeah. Manish, yeah, actually we fasting means what? Again, when that we have a less intake of water, of course the lithium level will increase. That's why in diarrhea, usually we say that when the patient is start having a diarrhea, usually we have to decrease the level. If there is a severe diarrhea, we have to stop the lithium because it can cause the lithium toxicity. Once the water intake is less, or in your fasting water intake is less, the lithium level will be high, Manish. Okay, so during diarrhea you have to be careful, and if the 1 to diarrhea is there, not severe, you have to increase your salt intake, because there is a, you will see the in physiology or pharma you will read that there is exchange of sodium and lithium in kidney. So if the sodium is more, the retention is less of lithium, less is lithium. Okay, yeah, okay Manish, yeah. So the toxicity, Manish, basically about lithium, if they ask the first clinical sign of lithium toxicity, if they ask the first clinical sign of lithium toxicity, the answer will be tremor in tongue, tremor in tongue. Okay, otherwise we have a side effects of lithium toxicity is what? Hand tremor, but the tremor in the tongue is a first clinical sign of lithium toxicity. Tremor in the tongue is a first clinical sign of lithium toxicity. Okay, okay. So this you have to remember. Lithium is a very important drug. I try to cover it, but please remember about lithium. It's a, they ask again and again. Okay. Next MCQ, a patient was admitted with complaint of tachycardia and arrhythmia. On examination, there was a scratch mark on the skin. The patient is most probably causing the, the which substance person is using. So that you have to remember. Basically, the answer will be, basically we have a cocaine. Okay. The cocaine we are getting from the plant, the erythroxylum coca. Okay, that you must have read, erythroxylum coca. Basically, initially this term of cocaine was given by Sigmund Freud. Okay, by the Sigmund Freud. And cocaine, they are asking cocaine, we also calling it a, the celebrity drug we can use through the the, we use orally, we smoke, and we through injectables, through IV we can use it. We sniff the cocaine. Okay, sniff. So basically sniffing of the cocaine, it basically causes the nasal septum perforation, nasal septum perforation. Okay, yeah, that you must have read. The main thing about cocaine, basically in cocaine, the toxicity, we have the symptoms like tachycardia, the arrhythmia we have. Okay, and apart from that, in intoxication, we can have a sweating, we can have a, hypertension. Okay, yeah. So, usually the other MCQ will come up about the substance, so about the alcohol and other thing I'll tell you simultaneously. But in this MCQ, the answer will be A for apple. Okay, only thing, one more thing about cocaine, please remember that cocaine basically causes the cocaine induced, psychosis. In cocaine induced psychosis, the patient will have tactile hallucination and paranoid delusion. Tactile hallucination and paranoid delusion. Okay, the patient will have a tactile hallucination, something, patient will say something, I'm feeling that something is crawling under my skin, tactile hallucination. Okay, we also, the another name of tactile hallucination is what we call them, cocaine bugs. Cocaine bugs. Okay, cocaine bugs, or we call it a Magnan symptom, or we call it a formication. So formication. Okay, yes, Magnan, yes, scratch mark, yes, Magnan symptom, Manish, because patient is thinking that something is crawling under my skin, and patient does this scratching there, and the scratch mark will be there in cocaine, Magnan symptoms. Okay, yeah. So the another name of tactile hallucination is cocaine bugs, Magnan symptom, or formication. So that you have to remember. This MCQ they are asking. Uncontrolled and excessive sexual desire in male is called. So answer will be the excessive sexual desire in male is, we have what? Satyriasis. So in male, the excessive sexual desire, we call it a satyriasis. The nymphomania is excessive sexual desire in female. Nymphomania. Okay, voyeurism, sadism, these are the, the perversion disorder you must have read in a forensic psychiatry. Voyeurism, person getting the gratification by seeing the, sexual object or the sexual act. voyeurism, sadism, person getting the pleasure by hurting someone, okay, giving pain to someone, it's a sadism. Okay, so that MCQ also there sometime asking, but that you it's a separate topic. But nymphomania is an excessive sexual desire in female, and satyriasis is actual excessive sexual desire in male. So in this MCQ the answer will be D4 daily. Okay, next MCQ, the a patient having a COVID infection around the 3 months back, but now present with the complaint of excessive sweating, palpitation, and the fear that he is about to die. The physical examination and investigation don't reveal anything. This is likely the diagnosis. So basically, patient, as we mentioned that in panic attack we have a symptoms like sweating, we have a palpitation, we have a fear. Today is I am going to die. Today is my last day. So the answer will be what? Panic attack. So that's why I mentioned that panic attack again and again they are asking. Okay, so the panic attack is will be the answer in this MCQ. Answer will be D4 daily. About PTSD, one MCQ is there, so we will discuss about that. In depression, the duration criteria of depression is 2 weeks. Duration criteria is 2 weeks. Yes, Manish, the answer will be D4 daily. The duration criteria for depression is 2 weeks, and for mania is 1 week. So we have to have a symptoms for mania 1 week, and the duration criteria for depression is 2 weeks. Okay, PTSD we'll discuss separately when MCQ is there. So we will, yeah, very true, Manish. Yes, we have impending doom in the panic attack. So patient will have feeling of impending doom. That patient is not having numbness. Person is numb. Person is so severely scared that today I am going to die. We call it a impending doom. Okay. Panic versus generalized. Yes, we will talk about, Manish. One MCQ is there, so we'll discuss about that. What is a generalized anxiety disorder? So the next MCQ, 72 hours of cessation of alcohol use. Okay, as the after 72 hours of cessation of alcohol use, that's a very important MCQ. And what are the new thing is there? We'll discuss about. Just a second. Yes. Okay. So basically the after 72 hours of cessation of alcohol use, which of the following is seen in patient with alcohol dependence syndrome? So that you have to remember. We have a simple withdrawal symptom, and we have a complicated. This you have to listen very carefully, because this is one MCQ. Very high chance that you will open the paper and that MCQ will be there. And that MCQ will be basically, the simple withdrawal symptom is we have a tremor, we have a sweating, we have a increased blood pressure, nausea, vomiting, sleep disturbance. Okay, this is a simple withdrawal symptom. Complicated withdrawal symptom, we have a what? We have a alcohol withdrawal seizure, we have a alcohol withdrawal delirium, and we have a alcoholic hallucinosis. Alcoholic hallucinosis. Okay, yeah. So in this, basically the first you have to remember that tremor, already I mentioned, it's the most common withdrawal symptom. They can ask you that tremor comes, it's a first symptom, it's a earliest withdrawal symptom. So within like 6 to 8 hours after stopping alcohol, person have tremor. Number one. Alcohol withdrawal seizure, when it will be there? Before, please remember, before we were saying that within 24 to 48 hours we have a after stopping alcohol, person can have alcohol withdrawal seizure. But now the latest CTP, the psychiatry book, basically what it mentioned that the within 12 to 48 hours. Okay, so before we were saying 20 to 48 hours, but now we say 12 to 48 hours. It's a very latest. Please remember, they can ask the new MCQ in your the coming exam. So before we were saying 24 to 48 hours, now we say that 12 to 48 hours. Alcohol withdrawal delirium. Alcohol withdrawal delirium, we were saying that before we were saying within 2 to 5 days, but now we say within 72 hours. So like within 3 days. 3 days. So that there are little changes is there in the this the complicated withdrawal symptom. Tremor appear within 6 to 8 days, sorry, 6 to 8 hours. Alcohol withdrawal seizure, before we were saying 24 to 48 hours, now we say 12 to 48 hours. The alcohol withdrawal delirium, we usually were saying that 2 to 5 days, but now we say within 72 hours. Okay, and the alcoholic hallucinosis also within 24 hours, within 20. So basically alcohol withdrawal the alcoholic hallucinosis is a earliest symptom, which like a complicated withdrawal symptom which appear earliest. Okay, so Manish, again I'm saying basically the patient stop the alcohol if they ask you the first symptom which appear, answer is tremor within 6 to 8 hours. Second, if they ask the alcohol withdrawal seizure after stopping alcohol, when it occurs, before we were saying 24 to 48 hours, but now we are saying 12 to 48 hours. Third MCQ, alcohol withdrawal delirium or delirium tremens, we were saying the onset of alcohol withdrawal delirium after stopping alcohol, the 2 to 5 days, maximum 7 days, but now we say that usually it occurs within 72 hours, within 72 hours. Okay, and the alcoholic hallucinosis within 24 hours. Delirium and dementia, Manish, the MCQ will come and we'll discuss about delirium and dementia. Okay, after a few MCQs there will be, so we'll discuss about it. Okay, so in this basically with after 72 hours cessation of alcohol, which of the following is seen in a patient with alcohol dependence syndrome? Answer will be yes, D for daily. Delirium tremens, delirium tremens. Okay, yeah, please remember, if they ask you alcohol withdrawal seizure, the treatment will be we just give the IV diazepam. Okay, in treatment we give the IV diazepam, in alcohol withdrawal seizure. Alcohol withdrawal delirium or delirium tremens, the treatment we will give the long acting benzodiazepines, long acting benzodiazepines in alcohol withdrawal delirium or delirium tremens. Okay, clear? Any queries? Okay, diazepam done. I'm writing very fast, so Manish, okay, I'm just speaking, so please try to understand that, because now it's a fast session, so we can't I write word by word, it will be very difficult. If you have somewhere problem in understanding, please let me know. Okay, done. Okay, because the space is very I have to write so many things, because this is my problem, I have to tell everything. The next MCQ, at the 34-year-old male came with the history of visual hallucination and disorientation. He was a chronic user of alcohol. Okay, tremens, yeah, delirium tremens, delirium. I have just written the alcohol withdrawal delirium, so I did not write the delirium tremens. A 34-year-old male patient came with a history of visual hallucination and disorientation. He was a chronic user of alcohol and last intake was 2 days back. What is the likely diagnosis in a given patient? Okay, so patient came with the history of visual hallucination and the disorientation. Okay, so that also you can understand, already we discussed that alcohol withdrawal delirium or delirium tremens. We have alcohol withdrawal delirium or the delirium, okay, tremens. Basically alcohol withdrawal delirium or delirium tremens is we usually have within 72 hours, already we discussed. And number two, the disorientation, in delirium, the Manish, you are asking what is the difference between the delirium and the dementia. So the first important thing you have to remember, the delirium is the disorientation, the cardinal feature. We have a disorientation or confusion. Okay, disorientation or confusion. So that's the main thing. Disorientation is a cardinal feature or delirium, and in dementia, patient remain conscious. Okay, patient remain conscious. So there is no disorientation in the dementia. We have a disorientation to time, place, and person in a delirium. It's a cardinal feature. Number two, in delirium, basically, it's an acute onset delirium. The dementia is a chronic onset, basically gradual onset. It gradually onset we have in a dementia. In a delirium, we have an acute onset. Okay, yeah. So the immediate and recent memory disturbance we have in a delirium, the remote memory remain intact. Yeah. No, in this MCQ, patient having a disorientation, visual hallucination. So basically, Manish, the answer won't be a alcohol withdrawal seizure. The answer will be alcohol withdrawal delirium. Answer will be B for Bombay, not A. Because please remember, we have usually uh, intake was 2 days back. Basically, there is no history given of a seizure. The history is given only visual hallucination and disorientation. So it will be delirium, not the seizure. In seizure, patient will have only seizure, and that's it. Okay, so yes, it can occur alcohol withdrawal seizure also within 12 to 48 hours, but the history is given of visual hallucination and disorientation is there. The answer will be more likely alcohol withdrawal delirium, not the alcohol withdrawal seizure. So in this, answer will be B for Bombay, not the A. Correct? What is the commonest emotional state? That you have to just mug up. Okay, directly you have to remember. Anybody can answer? What is the commonest emotional state? Yes, anybody? Yes, anybody can answer? Love, hate, anger, and fear. And the answer will be love. The commonest emotional state. There is a yeah, love. Very true, Dr. Vicky. Love, that everybody knows, huh? So the commonest emotional state is a love. Okay, that you have to remember. Sometimes they are asking directly, and we have to. Yes, very true. Yeah, Hamza. Answer will be love. That we won't discuss much about it. The important thing is the next MCQ is 24-year-old present with a history of excessive cheerfulness, increased activity level, excessive talking, lack of sleep for the last 10 days. What is the treatment of choice in this case? Okay, so please tell me the dear students, what's the diagnosis of this MCQ? What will be the diagnosis? Diagnosis will be mania. Okay, mania. So patient is more talkative. Yeah. Okay, okay. Yeah, so the patient will be the diagnosis will be mania. In mania, patient will have, more talkativeness, more cheerful, increase activity, increase energy, decrease need for sleep, grandiose ideas. Okay, overspending, over familiarity. In answer will be lithium, haloperidol, carbamazepine, and lorazepam. Yes, anybody? Manish, B for Bombay. Okay, okay. So its answer will be haloperidol. Why the answer haloperidol? Why not the lithium, carbamazepine, or lorazepam? So basically, the history is only we have since 10 days. So please remember, if they are giving the history of 10 days, or the first time they are giving the history, or the during the pregnancy, then we have to give the answer is what, the antipsychotics. Okay, antipsychotics. So during pregnancy also, please remember, during pregnancy also, if the first time examiner giving you it's a like first episode in pregnancy, first episode in pregnancy, and the examiner is saying that there is no past history, only the first time patient having an episode during pregnancy, and the history is given, then your answer will be antipsychotic. Before we were saying that haloperidol is a drug of choice during pregnancy, but now we say it's a olanzapine. the olanzapine. Okay, olanzapine. So before haloperidol and now it's a olanzapine. Correct? Yeah. For antipsychotic during pregnancy is olanzapine. Before we were saying haloperidol, still haloperidol we can use, but because it's a typical antipsychotic, there are more side effects. So in pregnancy, yes, safer antipsychotic is olanzapine. Okay. If they ask the safest mood stabilizer in the during pregnancy, what will be the answer? Yes, please tell me. What will be the answer during pregnancy? Which is the safest mood stabilizer in bipolar disorder? What's the safest mood stabilizer? Anybody? Please answer. What is the safest mood stabilizer during pregnancy? Can you tell? Answer will be lamotrigine. Answer will be lamotrigine is the safest mood stabilizer in the pregnancy. It's better than ox carbazepine. Okay, ox carbazepine. And if ox carbazepine is not an option, then the third one is a lithium. So please remember in that sequence that no, Manish, the safest is a lamotrigine. Lamotrigine, then if lamotrigine is not an option, then ox carbazepine. If ox carbazepine is not, then the lithium. Okay, then the lithium. Yeah. Lithium causes Epstein anomaly. The carbamazepine and the valproate, they cause the neural tube defect, but the chance of neural tube defect by the carbamazepine and valproate is much more compared to the Epstein anomaly caused by the lithium. So the third option will be the lithium. The first is a lamotrigine, the second is a oxcarbazepine, and the third is lithium. Okay. Okay, that you have to remember. Okay. Another MCQ they can ask, the you know, the in pharma you must have read, the carbamazepine is basically enzyme inducer. Oxcarbazepine is not an enzyme inducer. So all side effects are more with the carbamazepine compared to oxcarbazepine, but only side effect is less with the, you know, carbamazepine, and it is more with the oxcarbazepine. That is what hyponatremia. That please remember. So again, I am repeating, basically the carbamazepine causing the more side effect compared to the oxcarbazepine, only side effect which is lesser with carbamazepine compared to oxcarbazepine, and that is hyponatremia. So basically oxcarbazepine causes more hyponatremia compared to carbamazepine. Otherwise carbamazepine causing the more side effect because it's an enzyme inducer. It has a drug interaction. The oxcarbazepine is not an enzyme inducer, so it's basically safer than the carbamazepine, but oxcarbazepine causes more hyponatremia compared to carbamazepine. That you have to remember. And valproate also they asking, basically valproate is, you know, causing the teratogenic side effect of sodium valproate is what? The neural tube defect. Apart from that, the other side effect of uh, the valproate is basically, you know, alopecia. We have an increased liver function test. So valproate, they can ask you, valproate is basically increase the liver function test. So it can cause increase ammonia. Okay, so ammonia, it can increase ammonia, it can increase the, you know, the liver function test. So that they can ask. So in this answer will be haloperidol, because it's only since 10 days we have these symptoms. So the first choice will be haloperidol. Other they have given the previous episode or something they are asking, then you have to remember. If they ask the indication of lithium, what are the indication in which bipolar disorder patient will give the lithium? Number one, family history. If the patient came to you, patient is suffering from bipolar disorder, there is a family history of bipolar disorder, whether they received lithium or not, the drug of choice is lithium. Number one. Number two, no comorbidity. Basically the bipolar disorder patient, they having a other comorbid psychiatric disorder like you know, the personality disorder and substance use disorder. But please remember, if only pure bipolar, there is no comorbid other psychiatric disorder like personality or substance use disorder, then we give the lithium. So there are two important indication of lithium. Number one is the sorry, number one is family history of bipolar disorder, and number two, no comorbidity. The valproate, basically the indication is what? Number one, comorbidity like a personality or substance use disorder. Number 2, the dysphoric mania, we say the mania plus irritability. And we have a rapid cycling disorder. One MCQ is there, we'll discuss about that. If rapid cycling disorder, the sorry, the drug of choice will be valproate. Okay. In this MCQ, a 21-year-old girl suspect that the college principal is making some conspiracy against her, is planning to fail her in upcoming exams. He feels that other teachers have also joined the conspiracy, and students are helping them too. What is likely to just I take a sorry. I'll take little water. Sorry. Okay. She feels that other, yeah. Okay. So she feels that other teacher also having joined the conspiracy, and students are helping them to. What's the likely diagnosis in given patient? Yes. So basically, they are asking about the delusion. So in delusion, basically, patient in delusion of persecution, patient think that somebody wants to harm him. Okay, harm him, or somebody is having a conspiracy. So in this, the MCQ answer will be A for apple. Okay, delusion of reference, basically patient will think that if two people are talking about patient goes out, if somebody talking, the patient think that they are talking ill about him. Okay, so this is a basically the delusion of reference. Delusion of infidelity. Okay. Or we say the Othello syndrome, basically patient think that partner is unfaithful. The patient think that partner is cheating on him or her. Okay, so this is a delusion of infidelity or Othello syndrome. And we have a Cotard syndrome. Then Cotard syndrome is a in severe depression, patient think that his or her organs are not working. Cotard syndrome, I am just telling because again and again they are asking about the Cotard syndrome. In severe depression, we say Cotard syndrome, or we say delusion of nihilism. 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 Yeah, Cotard syndrome. No, Othello, no others. Cotard and the Othello syndrome is different. Othello syndrome is another name of delusion of infidelity. Okay, Othello syndrome. Cotard syndrome is basically the delusion of nihilism. In severe depression, patient thinks that his the organs are not. Suppose patient since 10 days not eating food, brought by the family member into the casualty, and patient and the family member are saying, sir, patient is not taking food since 10 days, and you taking a history, the history of depression comes, and patient saying, sir, my intestine is not working, I am not able to take food. Why? Because my intestine is not working. I'm not able to talk to you, my mind is not working. So because of severity of depressive symptom, others, basically patient start thinking that his the bodily functions are not working properly. This is a Cotard syndrome, delusion of nihilism, nothing exists, कुछ नहीं बचा, all my organs got rotten, मेरे organs सड़ गए हैं. This is a Cotard syndrome. Okay, Othello syndrome is another name of delusion of infidelity. Clear? Correct? Okay, so that they can ask. Done. So in this answer will be delusion of persecution. Patient think that somebody is planning to harm him or her. Somebody is having a conspiracy against me, somebody wants to kill me. Delusion of persecution. So answer is A for apple. Next MCQ, we have the a 14-year-old boy was, brought to the child psychiatrist by the parents. The parents reported that the child lies frequently at home and his school misbehaves with the teachers, often bullies younger kids, and has been caught stealing money on multiple occasions. What is the most likely diagnosis? So basically, the answer will be in this. What will be the answer? Anybody? Okay, okay. Answer will be okay. Somebody others is saying A. No, first thing, others, please remember that the boy is a 14-year. We don't make a diagnosis of personality disorder before 17 or 18 years of age. So please remember the antisocial personality is ruled out. Okay, yeah. Dr. Vicky, no, it is not antisocial because please remember it's a 14-year-old boy. 14-year means you can't make a diagnosis. Yeah, antisocial more than yes. So you have to make a diagnosis of any personality disorder only once the person is having a the age is 17 or 18. Okay, the patient is a less than 18-year, patient is a 14-year. Okay, so we have answer of this MCQ is a conduct disorder, not the antisocial personality. Yes, that is true that after some time, like once he achieved the adulthood, that he definitely, will convert into the antisocial personality disorder. But currently in this MCQ, we will make a diagnosis of conduct disorder. One MCQ, please remember here one important concept, that what is the difference between conduct disorder and oppositional defiant disorder. Basically, you can say that they are in the same spectrum, they are on a same page, the conduct disorder and oppositional defiant disorder. Basically, the oppositional defiant disorder is the oppositional defiant disorder is less severe. Okay, and the conduct disorder is a more severe. Okay, so oppositional defiant disorder is a less severe disorder and the conduct disorder is a more severe disorder. Basically, the setting fire, okay, the setting fire at home, okay, the breaking things at home, these are the symptoms we have only in a conduct disorder. And the other, like bullying, disrespect, disobey the parents, bullying the children, pelting stones on a cruelty, pelting stone on a doggy or animals, that's we can have in a both conduct disorder as well as oppositional defiant disorder. But setting fire, breaking things, only we have in a conduct disorder, we don't have in a oppositional defiant disorder. So ODD and conduct disorder on a same page. Okay, clear? Cluster C, what Manish you want to ask? Cluster C means what? You want to ask the personality? Personality? Personality, we have a cluster A, cluster B, and cluster C. Okay, so cluster A, we have a schizoid, the paranoid, the schizotypal. Okay, cluster B, we have a the okay, yeah, okay. So cluster B, we have a narcissistic, the we antisocial. So antisocial is not a cluster C, Manish, it's a cluster B. Antisocial personality disorder, the narcissistic, the histrionic we have. Okay, in a cluster B. Okay, and borderline personality. And in cluster C, we have a obsessive compulsive personality disorder, anxious avoidant personality, and dependent personality. Okay, so cluster C, anxious avoidant, dependent, and the OCPD. Cluster B, we have a narcissistic, we have a borderline, we have a histrionic, we have a antisocial. And cluster A, we have a schizoid, we have a paranoid, and we have a schizotypal. Correct? Okay. Yeah, I think we are covering nicely every topic. Are you enjoying, dear? Yes, dear students. Yeah, histrionic, Manish. Histrionic person is having a, so histrionic personality is basically the cluster B. Cluster B. Yeah, cluster B histrionic. Basically, histrionic person is like the very easily suggestible. Okay, he wants a center of attention. He, her, or his the color of clothes, the way of speaking, their mannerism will be in such a way that they want to be the center of attention. Easily suggestible people, easily sexually seductive people, this is a histrionic. Okay, So their manner, their way of talk, their color of cloth, they will be in a such a way that they want a center of attention in any gathering, anywhere they will go, they want a center of attention. This is a histrionic personality disorder. Okay, clear? Yeah. The next we have excessive fear of getting contaminated, repeated washing, repeated checking behavior, and excessive doubts are feature of each of the following. Okay, so in this, please remember the excessive fear of getting contaminated. The answer will be anybody. Yes, okay, very good. So answer will be obsessive compulsive disorder. So what in obsessive compulsive disorder they can ask again and again, they are asking this topic. So quickly I will tell you what important MCQ they can ask in OCD. What is the most common obsession? The most common obsession is contamination. Contamination. They ask them what is the most common compulsion. Anybody can answer what is the most common compulsion? Anybody? Okay, yeah, yes. So what is the most common compulsion? Anybody? What is the most common compulsion? Yes, anybody can answer. The most common compulsion will be, before we were saying it's a no. So Dr. Vicky, no, it's not washing. That's why I asked dear before. Please remember, before we were saying most common obsession is contamination, most common compulsion is the washers. But now we say the most common obsession is contamination, but most common compulsion is checkers, not the washers. Checkers. Please remember. So this is a very important MCQ. It's a checkers. It's not the washers. Okay, that you have to remember. That MCQ they ask. Okay. Second MCQ. Please ask in yeah. So if they ask that treatment of choice in treatment of choice, okay, the treatment of choice will be the ERP, exposure and response prevention therapy. Treatment of choice will be the exposure and response prevention therapy. So treatment of choice is exposure and response prevention therapy. If they ask the best modality of treatment, the best modality of treatment will be ERP plus SSRI or CBT plus SSRI. So ERP plus SSRI or CBT plus SSRI. Okay. And which is a SSRI, which is a most important SSRI we use for the in a OCD? It's a fluvoxamine. So before we were saying fluoxetine, but now we say fluvoxamine. Okay, now we say fluvoxamine. Okay, yeah. And please remember the OCD is a psychiatric disorder where we use the surgery. Okay, or in OCD we use the surgery, cingulotomy, white fiber tract we cut, surgery. And we use the in OCD basically we use deep brain stimulation. We also use the deep brain stimulation. Okay, yeah. Between OCD and OCPD, Manish, basically OCD is a obsessive compulsive disorder and OCPD is a obsessive compulsive personality disorder. So basically in OCD we have this contamination, we have a religious obsession, we have a symmetry obsession. Okay, in compulsion we have a checkers, we have a washers. But in OCPD, patient having a the very perfect way of doing things. He or she wants to do the any work in a very particular manner. Like we say that Mr. Amir Khan is a Mr. Perfectionist. So they basically, suppose you are writing in even a single word you did not write correctly, you will tear the page and you will rewrite it again. This is a OCPD. Basically they want to do things in a very perfect manner, and that's why there is a delay in work, because they do the things again and again. This is so issue of perfectionism, issue of stubbornness. Okay, issue of stubbornness, issue of, so they are very stubborn in a their work. They don't like people who don't do according to them, so they want work in a very particular way. So OCPD is related to personality. It's a personality disorder. Perfectionism, stubbornness, delay in work, OCPD. And OCD is a psychiatric disorder where we have a obsession and compulsion. Okay. Okay, symmetry. Yes, symmetry. We have obsession. Okay, so clear about this OCD. They can ask these area. They can also you should know. Uh, the next MCQ: a 43-year-old male reports that after sudden financial loss, he developed certain symptom. He feeling fearful that someone is about to harm him. He could not sleep and eat properly. He also began to hear voices of female. That voice will abuse him and say that he was useless and should kill himself. His symptoms stopped after approximately 1 week. There was no relevant past history of drug abuse and medical history. What is the following most likely diagnosis? Anybody? Okay. Okay. Somebody is saying D. Okay. Please try. Please try. What's the answer? Anybody? So we have a ICD and we have a DSM, dear students. So we have a two classification in psychiatry. We have an international classification of disease, and we have a diagnostic and statistical manual of mental disorder, DSM. Okay, yeah, very true. Okay, now you are changing your option, so please be careful. Just change in your mind, but don't in your answer sheet. Okay, yeah, ICD and DSM. Okay. Yeah. In ICD we have a uh, we have a schizophrenia, and we have a acute psychosis, and in DSM we have a schizophrenia, and we have a brief psychotic disorder, and we have a uh, schizophreniform disorder. So basically, please remember one thing: in ICD, if the duration is less than 1 month, we call it a acute psychosis. The duration is 1 month or more, we call it as schizophrenia. Okay, so number one, schizophrenia in ICD 1 month or more, and the less than 1 month acute psychosis. In DSM, we have a schizophrenia, we have a brief psychotic disorder, and we have a schizophreniform. So please remember, in DSM, if the duration is less than 1 month, we call it a brief psychotic disorder. The 1 to 6 months, the schizophreniform disorder, and the 6 months or more, we call it a schizophrenia. So less than 1 month brief psychosis, 1 to 6 months schizophreniform, and 6 months or more is a schizophrenia. Okay, so that you have to remember. In this MCQ, the symptoms stopped after approximately 1 week. So the duration is less than 1 month, so answer will be brief psychotic disorder. If it is given 1 to 6 months, then we call it the schizophreniform, and 6 months or more, we call it a schizophrenia according to DSM. That you have to remember. Okay. Schizoaffective disorder, we say the person is having a schizoaffective one concept. Briefly, I'll tell you in MCQ if they ask. Basically, in schizoaffective, the patient is suffering from schizophrenia. Suppose patient since 2 years, patient is suffering from schizophrenia. Now, in these 2 years, before we were saying that if patient having a only like 2 weeks depressive episode, or we say 1 week manic episode, then we used to call it a schizoaffective. But currently the DSM-5 says that if the 2 years patient having a symptoms of schizophrenia, suppose 2 years, so if we want to call it a schizoaffective, the mood symptom also should be almost for 2 years. Okay, so the symptom of the schizophrenia should be the affective symptom, or the mood symptom also should be at almost for 2 years. So 2 years the schizophrenia, before we were saying like 2 weeks or the 1 week manic or depressive symptom, it is sufficient. Now we say that 2 years the schizophrenia. If we want to call it a schizoaffective, the symptoms should be almost for 2 years, then only. So before we were saying cross sectional, now we call it a longitudinal. Okay, if you can remember, but that schizophreniform and brief psychotic you have to remember. So the answer in this MCQ will be B for Bombay. B for Bombay. Okay, so it's not D, it's B. Correct? Very nice. Okay, next is yeah, that you have to tell me what will be the. A college student was referred for evaluation. He was having a difficulty in study. So what will be the 55 IQ is there. So in which what will be the diagnosis? So the mild MR is what? You know, we have 50 to 69. Moderate is 35 to 49, and we have a severe 20 to 34. Okay, so 20 to 34 mild, the 35 to 49 moderate, and the 50 to 69 we say mild. So mild is 50 to 69, moderate is 35 to 49, and severe is 20 to 34. Okay, the borderline intelligence, so we say less than 70 is mental retardation. Okay, mental retardation. The new name is intellectual disability. So the new name is intellectual disability. Okay, of mental retardation, the intellectual disability, or we say the intellectual you know uh, disorder. So the in DSM-5 and in ICD-11, now we don't prefer the mental retardation, we call it a intellectual disability. Okay, the borderline intelligence we say the 80 to 90, because the 90 to 109 is normal. 90 to 109 is normal. The less than 70 we say the basically. Okay, just a second. So this is mild, moderate, and severe. Clear? Mild is 50 to 69, 35 to 49, and we have a 20 to 34. Again and again they are sometime asking, so you should remember this. Okay, 90 to 109 is normal. Please remember one thing, before nowadays they are sometime they can ask. Before we were saying one is, we say moron, moron. We say the imbecile, and we say idiot. Okay, so moron we say, what's IQ of moron? It's a 51 to 70. Okay, the imbecile we say 26 to 50. Okay, 50, and the 0 to 25 is idiot. Okay, so that they can sometime they can ask, if they ask. So moron, imbecile, and idiot. Usually we use the word idiot, but idiot is too idiot, it's just 0 to 25. So for if you are saying your friends, usually start saying the moron but not the idiot. Okay, so even sometimes we use the word idiot, but idiot is too idiot, it's a very low IQ. So moron is a better word, okay, rather than saying the idiot. Okay, clear? This is mild, moderate, and severe. Now next is clear, the mental retardation, the IQ they can ask. So be very okay. The next is 23-year female complain of difficulty in sleeping at night. She says that so in this, yes, answer will be it's a mild MR. That I hope you are clear now. A 23-year-old female having a difficulty in sleeping at night, she says that she gets thought or that her parents may die in an accident. She similarly has many other worries. What's the most likely diagnosis? Generalized anxiety disorder, adjustment disorder, obsessive compulsive, and panic disorder. Correct? Yeah. Yes, Manish. Yeah, Manish is little now, you know, cheerful, huh? Correct? Very true. No, the life is more important, dear friends. एग्जाम आते हैं जाते हैं बट लाइफ चलती रहनी चाहिए. So nothing to worry. Just study well. Have a good, like revision of these 10, 12 subjects. The basic and minor subjects are very important in your this FMG exam. Just you have to be very careful about the basic and minor subject. In this MCQ, yes, the answer will be generalized anxiety disorder. Oh, so in generalized anxiety disorder, Manish, you are asking that we how we differentiate between the panic attack and generalized anxiety disorder. Okay, yeah. So yes, Dr. Vishal, generalized anxiety disorder. So in this, basically, we have a major symptom and we have a minor symptom. Minor symptom. Okay, in major symptom, we have a unnecessary worry, but patient is not able to control that worry. Unnecessary worry, but patient is not able to control that worry. And the minor symptom is patient having a like irritability, patient having a sleep disturbance, fatigability, okay, decreased attention, concentration. So we have a two major criteria, we have a six minor criteria for making a diagnosis of uh, generalized anxiety disorder. We need two major criteria and three minor criteria at least for 6 months. So basically, generalized anxiety disorder is a free floating anxiety in every domain. Person will have unnecessary worry about everything. He or she knows that they are having unnecessary worry because it's a neurotic disorder. Insight is present, but patient is not able to control that worry, and because of that he's having a restlessness, he's having a irritability, he's having a fatigability, decreased attention, concentration, sleep disturbance. Okay, these are the minor symptoms are there. And if we have a two major criteria and three minor criteria at least for 6 months, then we call it a generalized anxiety disorder. So that you have to remember that patient having worry about the die in an accident. Similarly, they having a many other worries. Clear? Yeah. Post-traumatic depression, no, Dr. Vishal. Even in post-traumatic, it won't be. Post-traumatic will come, so we'll discuss about that. Don't worry. We'll discuss about that. How to differentiate the PTSD and the generalized anxiety disorder. One MCQ is there, so we will discuss about that. Clear? Okay. A 34-year, yeah. The next MCQ, the 34-year-old, the patient has six episodes consisting of mania, hypomania, and depression. In the past 1 year, there was complete recovery in between the episodes. What's the likely diagnosis? Okay, yes, the answer in this, anybody? So it's very easy to answer. So please tell what's the answer in this MCQ. Yes, very true. Rapid cycling bipolar disorder. So the rapid cycling bipolar disorder is basically the very true, four or more episodes. Four or more episodes in last 1 year. We call it a rapid cycling bipolar disorder. Very true. The four or more episodes in last 1 year, we call it a rapid cycling bipolar disorder. Rapid cycling bipolar disorder. The drug of choice will be, please remember, the sodium valproate. Sodium valproate. Yes, sodium valproate. Dysthymia. The another name of dysthymia is what? Persistent depressive disorder. The new name of dysthymia is what? Persistent depressive disorder. Persistent depressive disorder. Dysthymia. Dysthymia, persistent depressive disorder. Patient will have at least subthreshold symptom for 2 years. So subthreshold depressive symptom, at least for 2 years or more. The symptoms are subthreshold. They are not able to fulfill the syndromal criteria of depression, but symptoms are there. The subthreshold depressive symptom. The duration is 2 years or more. Another, the new name in DSM-5 of dysthymia is persistent depressive disorder. Cyclothymia, uh, and again the symptoms are 2 years or more, but in dysthymia we have only subthreshold depressive symptom, but in cyclothymia patient will have a subthreshold depressive and hypomanic symptom. So few hours patient will have a depressive symptom, maybe few hours he or she will have a hypomanic symptom, but neither the depressive nor the hypomanic symptom are able to fulfill the criteria of depression or the mania. So this is a cyclothymia. And major depression you must have read. So this is a, in this MCQ answer will be rapid cycling bipolar disorder. Correct? A child is referred by the school. Basically, he faces difficulty in making proper sentences. Otherwise, his intelligence level is appear normal. So in MCQ, you have to focus on every, there is not a single word usually examiner giving the just for sake of giving. Okay, so you have to be very careful about reading MCQ. Many time, if you have a good concept about the topic or subject, the MCQ itself will tell you the answer. Yes. So the child having a normal IQ, he is good in mathematics, his social behavior is also appropriate. What's a likely diagnosis? So basically, see in this MCQ, if you'll see, if the intelligence is normal, the mental retardation is ruled out. Correct? Yeah. In depression, patient is nothing to do with the intelligence or the making proper sentences. So depression or the exam phobia is also ruled out. So basically, we have to be careful about what about the how to rule out the options. Okay, so specific learning disorder, yes, SLD will be the correct answer. SLD will be the correct answer. In SLD, basically patient will have like the Tare Jami Amir Khan made the movie, it was on this SLD, the dyslexia, the slang language we are using, specific learning disability. Yes, Siddharth. So basically in this person either will have a difficulty in reading, the writing, either he will read the u instead of v, the w instead of am. So the problem in the reading or the writing or the mathematics, and sometimes we have a difficulty mix like reading, writing and mathematics together. So this is we call a specific learning disorder. Only thing you have to remember, the IQ should be normal in specific before making a diagnosis of specific learning disorder. We have to be very clear, the IQ should be normal. If IQ is not normal, it means that the child doesn't have an issue of a specific learning disability disorder, the child having an issue due to IQ. So for making a diagnosis of SLD, IQ should be normal. Okay, SLD is very important because nowadays we are giving a lot of the facility to these children who is suffering from SLD. They are getting they get exemption from a specific language like German language or any other languages. They get the calculator during the examination, in examination hall. They get the special assistance, during examination. So there is a government providing lot of facilities. So please, being a doctor, be very aware about it, and you can help your relatives, your known people about, because many people are not aware about the psychiatric disorder, and also they don't want to they don't want to accept also. So sometimes this is a issue. Okay, okay then. The answer will be specific learning disorder. Next is we have the 35-year old patient with a history of chronic alcohol use was admitted and operated for acute appendicitis. After the surgery, the patient appeared confused and reported seeing the snakes in the wardroom. What is a likely diagnosis in the given case? Okay, so 35-year-old patient with a history of chronic alcohol use was admitted and operated for the acute appendicitis. After the surgery, patient appeared confused, reported seeing snakes in the wardroom. What's the likely diagnosis in the given case? In this patient having a after the surgery, the confusion is there, the patient having a seeing the snakes, so visual hallucination is there. So usually we have the answer is what? So patient having a chronic alcohol, and after surgery of course he stopped the alcohol, and after stopping the alcohol, yes Manish, the answer will be delirium tremens. So see, delirium tremens, this delirium dementia, again and again they are asking. So you have to be very careful. This MCQ they will ask. Yeah, so about delirium, the cardinal feature, the quickly I'll tell you about the delirium. The cardinal feature, alcoholic hallucinosis? No. Please remember, Manish, the alcoholic hallucinosis won't be the answer, because in alcoholic hallucinosis, patient will have only complaint of auditory hallucination. Complaint of auditory hallucinations. There will be, the patient will be no disorientation. Patient will be fully conscious. That you have to be very careful about this. So in alcoholic hallucinosis, patient will say, sir, when I don't take alcohol, I started hearing some voices, but when I take alcohol, I don't hear voices, so I keep taking alcohol, because sometimes alcoholic hallucinosis become reinforcer for taking alcohol. But please remember, in alcoholic hallucinosis, patient never will have a disorientation. Okay, so that you have to be very careful about that. If disorientation examiner is talking about, it's a delirium. Okay, in alcoholic hallucinosis, only complaint is of the complaint of what auditory hallucination, but there is no uh, like disorientation or the confusion. Okay, yeah, yes, visual hallucination common in alcoholic, but it's a delirium tremens. It's not alcoholic hallucinosis. In alcoholic hallucinosis, only issue will be of what, the auditory hallucination, no other confusion, no disorientation. It's about delirium. Please remember, in delirium, the cardinal feature of delirium is what? Disorientation. And disorientation to time, place and person. Time, place and person. Clear? Oh, and then there is a memory deficit of immediate and recent memory. The remote memory remain intact. The treatment of delirium, please remember, it's not about delirium tremens. The treatment of delirium is what? That treat the etiology. Treat the etiology. And what is the cause of delirium? You have to treat the cause. And the benzodiazepines are contraindicated in delirium patient, except alcohol withdrawal delirium and the benzodiazepine withdrawal delirium. All other delirium benzodiazepines are contraindicated. No, Manish, usually benzodiazepines are contraindicated in delirium patient. We have to, in the benzodiazepines we give only in alcohol withdrawal delirium or delirium tremens and benzodiazepine withdrawal delirium. All other delirium patient, the benzodiazepines are contraindicated, because if the side effect of benzodiazepine is what? Cognitive deficit. So if you give the benzodiazepine, patient condition is going to worsen. So benzodiazepines are contraindicated in delirium patient. Only we have to give the benzodiazepines, the drug of choice, in delirium tremens or alcohol withdrawal delirium patient. Clear? Okay, the next is, yeah, a 23-year-old lady presented with the sudden onset of chest pain, palpitation lasting for about 20 minutes. He says the 3 episode similar in the past. All investigations are normal. What's the likely diagnosis? Already we discussed. It's a panic attack. So already we discussed it. So we won't give much time to. Yeah, the next MCQ. The all are stages of death. Which of the following is not included? So there was a person. Kubler-Ross. Kubler-Ross basically, he has given the stages of death, and he has given the stages dabda. There was a mnemonic dabda. D for denial, A is anger, B for bargain. Okay, then the D for depression, and the A for acceptance. So initially person remains in a denial, then there is the person get angry, then person get bargain with the god, why you have chosen me, not other people, and then the person goes in a depression, and then the last is acceptance. Yes, it has happened, and now I have to accept it. Then, so this is the dabda. So denial will be there, the anger will be there, the bargaining will be there, agitation won't be there. So it's not a stages of death. Please remember, D for daily. Okay. Many people got this answer wrong. So it's a DABDA: denial, anger, bargain, depression, and acceptance. Agitation won't be the stages of death. Clear? So answer will be D for Delhi. Which of the following is not a formal thought disorder? Yes, in formal thought disorder, we have a neologism is a formal thought disorder. The derailment is a formal thought disorder. Tangentiality is a formal thought disorder. So the derailment, the neologism, the tangentiality, okay, circumstantiality, they are the formal thought disorder we have. So formal thought disorder in schizophrenia patient is not able to put their sentence in the sequences, okay, and their speech is disjointed speech. We call it a formal thought disorder. And the subtypes of formal thought disorder, we have a neologism, we have a derailment, we have a tangentiality, we have a circumstantiality, okay, we have a thought block. There are so many subtypes of formal thought disorder. Delusion is a basically we have a mental status examination, MSc. In mental status examination, we have various heading and subheading. We interview the patient, we do the mental status examination, and within like 30-40 minutes we'll come to know that what the patient is suffering from, what is a patient diagnosis. So delusion basically comes under thought content. Okay, delusion comes under thought content. So delusion is a basically disorder of thought, that you have to remember. Disorder of thought. Delusion is a disorder of thought. Disorder of thought. That we have, so we have formal thought disorder, and delusion is a disorder of thought, and the obsession comes under disorder of possession of thought, that you have to remember. So obsession comes under possession of thought, delusion comes under thought content, disorder of thought, okay. Yeah, so again I'm repeating that we have a formal thought disorder. In formal thought disorder, we have Manish and other dear students, we have a formal thought disorder, we have a neologism, we have a derailment, we have a tangentiality, we have a circumstantiality, we have a thought block, we have a neologism. They comes under the formal thought disorder. This delusion is a disorder of thought. Basically delusion, we have one heading in mental status examination, thought content, and delusion comes under thought content, that you have to remember. Delusion comes under thought content, and the obsession comes under disorder of possession of thought. So we have a thought insertion, thought withdrawal, and thought broadcasting, and obsession, they comes under possession of thought in mental status examination. Clear now? The delusion comes under the thought content, and the obsession comes under possession of thought, disorder of possession of thought. Clear? Okay. Clear? Now, to diagnose post-traumatic stress disorder, the symptoms should persist for how long? So I think Vishal or somebody was asking about the PTSD. We will discuss about it. The PTSD, basically we are making a diagnosis. PTSD patient will have a any one, we have a stressful condition, which can be stressful for one person but not for other person, and one we have a catastrophic event. Catastrophic event by definition is an event which causes stress in almost everyone. So like rape, like tsunami, like earthquake, like flood, like the major accident, sexual abuse, they are the examples of catastrophic event. So the first criteria of PTSD is patient should have a catastrophic event. Number two, the second criteria, the flashback of those events in your thoughts and dreams. That's the second criteria. The third criteria, patient will have a hyperarousal symptom, anxiety and depressive symptom. And the fourth criteria, patient will have a avoidance behavior. Suppose you had a major accident, or on a particular road, you will not feel like going there in future. So these are the criteria of PTSD. We usually, when we make a diagnosis of PTSD, up to 1 month, we call it a acute stress disorder. Acute stress, and 1 to 6 months we call it a PTSD. So up to 1 month we call it a acute stress disorder, and just 1 minute, I'm coming back. Huh? No? No. No? Okay. Okay, so we were discussing the post-traumatic stress disorder. The symptoms should persist for how long? So up to 1 month we call it a acute stress disorder. 1 to 6 months we call it the PTSD. Mm, and usually we make a diagnosis of PTSD within like 6 months, but we can make even after 6 months. The EMDR, before we were saying the EMDR, we use the eye movement desensitization and reprocessing, we call it we were using in a treatment of PTSD, the eye movement desensitization and reprocessing. But currently we say the EMDR is not a good therapy. Currently we use CBT, cognitive behavioral therapy. Cognitive behavior therapy. Okay, cognitive behavioral therapy. The the fear of places. So now clear, Vishal, about the PTSD. The next MCQ, the fear of places from which the escape is difficult, is called we call it a agoraphobia. Agoraphobia. Okay. So basically, agoraphobia is a most common type of phobia. Okay. The aerophobia is a fear of height. The claustrophobia is a fear of closed space. Allurophobia is a fear of cats. Okay. And we have a nyctophobia. Nyctophobia is a fear of dark places. Fear of dark places. Okay. Fear of dark places. So so closed space, the height, the okay. Now in phobias, the treatment of choice, if they ask, that it's a behavior therapy. The behavior therapy. Behavior therapy. Neologism is seen in which of the following? Yes, already we discussed. It's a one of the formal thought disorder. It was seen in what? Schizophrenia. So basically, the schizophrenia, we have a neologism. It's a completely new word by definition. Completely new word which can't be derived from the. It's a completely new word which can't be derived from the any yeah any vocabulary or dictionary by definition. Neologism. So neologism we seen, it's a very characteristic symptom of schizophrenia. Manish, it's the up to 1 month we say the acute stress disorder. 1 to 6 months we make a, if the symptoms are there, we make a diagnosis of post traumatic stress disorder. Clear? Okay. Yeah, hello. A woman has mild depressive symptom after a few days of delivery, which disappears within 2 weeks of the postpartum period. So that you have to, it's a very important MCQ. The like postpartum blues, postpartum depression. When we make a diagnosis, the onset of the postpartum blues onset is 3 to 5 days, and usually we have up to 2 weeks. Okay, so onset is 3 to 5 days, and then we have a up to 2 weeks. Postpartum depression is we have, so up to 3 to 5 days, and then we have up to 2 weeks. Clear? 3 to 5 days, and then we have up to two weeks. Postpartum depression, we have a onset. Usually we after delivery up to 1 month, we usually say we can make a diagnosis. If the option 6 months, Manish, usually we make up to 6 months, but we are making a diagnosis of PTSD after 6 months, we call it a PTSD of delayed onset. We call it a PTSD of delayed onset. But usually we make a diagnosis of PTSD up to 6 months, but if we make a diagnosis after 6 months, we call it a PTSD of delayed onset. Okay. Clear? Yeah. Now, postpartum blues, we have usually onset 3 to 5 days within after delivery. Within 2 weeks, the symptom disappear. Symptoms are usually irritability, sleep disturbance, okay, the crying spells, but we don't have a many depressive symptom in postpartum blues. The treatment is basically usually patient get rest, emotional support from the family member is a usually treatment in postpartum blues. No medication is required in postpartum blues. No medication is required in postpartum. No medication is required. Okay. Yeah. Clear? Postpartum depression, we are making a diagnosis up to like 1 month. Sometime we say up to 3 months also after delivery. Postpartum psychosis, usually also onset is around 3 to 7 days. We have in postpartum psychosis, patient will have psychotic symptom. So that's how you usually we start the postpartum depression. It starts around 2 weeks after delivery. It only starts, there is a clear cut depressive symptom. In postpartum blues, the onset is around 3 to 5 days. Within 2 weeks, the symptoms disappear. Okay, yeah. Suicidal thoughts we have in depression, but not in postpartum blues. And there is no medication is required in postpartum blues. Only emotional support from the family member. This MCQ again and again they are asking. So few days disappear within 2 weeks. So answer will be postpartum blues. Answer will be A. Not a fundamental symptom of schizophrenia. So the Eugen Bleuler has given the name schizophrenia. So there was a Emil Kraepelin who has given the name dementia precox, and Bleuler has given the name schizophrenia. Okay, he has given the symptom like autism, the association disturbance, ambivalence, and the affect disturbance. Okay, so there is a affect disturbance, association disturbance, ambivalence, and autism. Automatism, dear students, is not a symptom of schizophrenia. So the Bleuler has given the 4A of Bleuler. The name came 4A of Bleuler. Basically, Bleuler has given the 4 symptom: autism, ambivalence, association disturbance, and affect disturbance. Okay, affect disturbance. So the autism was the 4A of Bleuler, not the automatism. Manish, answer is not A. Answer will be B. B for Bombay, because autism was a 4A of Bleuler, not the automatism. Automatism is a symptom of what? CPS, complex partial seizure. Okay, so an answer will be yes, not A. Answer will be B for Bombay. Okay, clear? Most commonly psychiatric illness seen in medico-surgical patient in which of the following? That yes, already we discussed. The delirium is a most common organic disorder. Most common psychiatric illness, you can say, most common organic disorder. So it's a delirium. Most common psychiatric illness in medical surgical patient. We have medical surgical patient, there is a hyponatremia, there is a hypokalemia, and we have a delirium. And delirium is a basically already we discussed in detail. So delirium is the most common psychiatric illness in medical surgical patient. The double depression in which of the following? The double depression we have basically patient having a dysthymia. On top of dysthymia, if the patient having a depression, we call it a double depression. So dysthymia plus depression, we have a double depression. Dysthymia plus depression, we call it a double depression. Okay, yeah. Answer will be C for Calcutta. The most common, the acute organic mental disorder is which of the following? Already I told you that we have a most common psychiatric illness in medico surgical cases, it's a delirium. Most common organic mental disorder is also, answer will be delirium. Answer will be delirium. About dementia, please remember they ask the Capgras syndrome is associated with what? Dementia of Lewy bodies. Dementia of Lewy bodies. Dementia, please read carefully. Before we had a rivastigmine is an anti-dementic drug which we have the transdermal patch, but nowadays we have donepezil also, which comes in the transdermal patch. Okay, in transdermal patch. So rivastigmine and the donepezil. Okay, they both come in a transdermal patch. So if they ask the which medication, we don't have a, like we should not, we can't take orally. The patient, suppose the recent MCQ has been asked, the patient don't want to take a medication, uh, orally, don't want to accept the medication for orally for the dementia patient. For the dementia, what medication will choose? So rivastigmine, already since many years it's coming as a transdermal patch, but now the recently the donepezil also started coming. Okay, next MCQ. Next MCQ, a non-diabetic, non-hypertensive patient has some extra beat in pulse. Doctor informed it's a benign, but patient is still going for investigation from doctor to doctor. So basically, this type of, it's a hypochondriac disorder. The new name of hypochondriasis is what? Illness anxiety disorder. Illness anxiety. So the new name is what? Illness anxiety disorder. Basically, in hypochondriasis, what happens? Patient having a preoccupation regarding serious illness. The minor benign symptom or the normal physiological function appear like a serious illness for the patient. So the another name is what? Illness anxiety disorder. Okay. The next is, which of the following is true for disulfiram therapy? Which of the following is true for disulfiram therapy? Basically, in disulfiram therapy, it's a aversion therapy. Basically, what disulfiram does, it's inhibits the aldehyde dehydrogenase enzyme. Okay, so alcohol converts into basically the alcohol converts into acetaldehyde, and the acetaldehyde convert into the the further we have acetoacetate. So basically, when patient takes the disulfiram, patient will have a metabolism of alcohol into acetaldehyde, but person will not convert into the acetaldehyde will not convert into the acetoacetate. So acetaldehyde get accumulated in the body, and it gives the disulfiram ethanol reaction. It gives the disulfiram ethanol reaction basically. Okay, so we call it a aversion therapy, because patient took the alcohol today on disulfiram, patient got the disulfiram ethanol reaction. Even next time patient will think about the alcohol, patient will have a aversion reaction. That's why we call it a aversion therapy. Okay, anti-craving agent we have. Basically, disulfiram bind the patient, but patient the disulfiram is nothing to do with the craving of the alcohol. So basically, patient can say, sir, you bind, no, the Manish, hypochondriasis and factitious is different. Hypochondriasis is a normal benign symptom, or the normal physiological function or benign symptom appear like a serious illness. Factitious disorder, patient basically present the symptom intentionally. Patient doesn't have any symptom. Manish, patient just present the symptom to gain the medical attention. So factitious disorder is a conscious effort. Patient doesn't have any symptom, despite that, to gain the medical attention, he or she present the symptom. So this is a factitious disorder. Okay, and it's entirely different from the hypochondriasis. Anti-craving agent, we have, yes, we have acamprosate. We have a baclofen. We have acamprosate, we have a baclofen, we have a So acamprosate, baclofen, topiramate, and we have a naltrexone. So acamprosate, baclofen, topiramate, and naltrexone. Acamprosate, baclofen, topiramate, and naltrexone. These are the basically anti-craving agent. We have the safest anti-craving agent in liver disease is acamprosate. That please you remember. It's safe in liver disease because the people who take alcohol, they have a very high chance to having a liver disease, but it's a safest. Yeah. One is malingering. Basically, malingering and the factitious disorder, only remember that both are conscious effort, both are intentionally produced. In factitious disorder, only intention is to gain the medical attention, but in malingering, the intention either job related gain or financial gain. So the factitious disorder and malingering patient does it consciously, patient intentionally produce the symptom. The only intention in factitious disorder is to gain the medical attention. In malingering, is intention is to either get the any financial gain or job related gain, but not the medical attention. So medical attention in factitious disorder, and in malingering the job related gain or financial gain. Clear? These are the anti-craving agent. The indoor okay, clear? Okay. The next MCQ, indoor management of anorexia nervosa is done on priority patient with which of the following. Basically, the indoor patient, the binging episode, no. Amenorrhea, no. We will admit the patient if the patient having a weight of less than 75% of normal. So usually one of the criteria of the anorexia nervosa is what? Less than 85% of normal weight. What weight is even less than 75%, it means there is a seriousness of the symptom is there, and that one of the indication of anorexia nervosa. Okay, the anorexia nervosa, bulimia nervosa also there. I hope you have read it very nicely. Just remember only scope criteria. Scope criteria are, it's a questionnaire we use in eating disorder. That MCQ they can ask in recent exam, they ask. So scope criteria, if they ask the scope criteria where we use, so scope criteria we use is scope questionnaire or scope criteria we use to diagnose the eating disorder. That you have to remember. Okay, CBT we use in anorexia nervosa. Anorexia and bulimia nervosa quickly read, because this is a MCQ they can ask in eating disorder. Next is 7-year-old child who don't interact with other children of his age group, and the prefers playing alone in the same manner, is likely to suffering from which of the following. Yes, answer will be autism. Answer will be autism. Okay, so the don't interact, playing alone in the same manner means stereotype behavior. So this is a autism. Nowadays we say autistic spectrum disorder. Autistic spectrum disorder. So autism, the first criteria of child having a language and communication disturbance. Because of language and communication disturbance, there is an impairment in social interaction, and there is a stereotype behavior. Stereotype behavior. Answer will be autism. Clear? Okay. Now which of the following is a key feature symptom of depression? The key feature of depression is, please remember, sadness of mood. Sadness of mood. So this is a key feature of depression, sadness of mood. Sadness of sad mood. It's the most important key feature that MCQ they can ask. So that please remember. A patient in OPD is very, very much obsessed about the particular thing. He seemed to be stubborn, and the about the nature. As Sigmund Freud, basically the psychosexual stages fixation happened. So oral phase we have 0 to 1.5 year. Anal phase we have 1.5 to 3 years. The phallic phase we have 3 to 5 years, and the latent phase we have 5 to 11 years, and the genital phase then we have 12 years and further. So oral phase, the anal phase fixation occur, OCD. In oral phase, if the fixation occur, it's a schizophrenia and substance use disorder. That you have to remember. So if we have a fixation in the oral phase, the schizophrenia and substance use disorder. If the fixation occur in a anal phase, then the OCD. If fixation occur in a phallic phase, then we have a dissociative disorder. That you have to. dissociative disorder. Okay, dissociative. Done. That you have to remember. So answer will be anal phase. It will be anal phase for OCD. Anal phase B for Bombay. Next is a female gives birth via the vaginal delivery. After the 5 days of delivery, she presents with the complaint of restlessness, difficulty in sleep, sadness, and irritation. So 5 days of delivery, of course, days of delivery, restlessness, difficulty sleep. These are the symptoms we have after 5 days only. We have in postpartum blues. So this MCQ again and again they are asking. So postpartum blues, postpartum depression. You have to be little careful about these MCQs. So already we discussed. So answer will be C. A young man gets a sudden irresistible urge to take the action. This condition is classified as. So we have the sudden irresistible urge. The answer will be impulse. Will be okay, impulse. That you have to remember. Illusion and all these things we have discussed. And the one MCQ we have, a patient had a long standing history of alopecia and abdominal pain, nausea, vomiting, weight loss during stomach surgery. Below shown the foreign body was recovered. What's the likely diagnosis? That you know that it's a yes. The answer will be trichoephagia. Basically it's about patient having an ingestion of hair, your trichophagia we call it. So it's found in a basically in a female, in adolescent female we have who having a issue of trichophagia or trichotillomania. They take the hair, they pull the hair, they start eating hairs, and this balls we have in a stomach, and there's a sometime even obstruction of the stomach or the intestine. This is then so the answer will be C for Calcutta. C for correct. So see, this is the total CQ. So I hope guys you enjoyed. I try to cover as much as possible in 2 hours. Enjoyed? Yes. So what you say? The way we discuss psychiatry, again I am repeating, it's an important subject. So please go through this. What are the topics? As I told, antidepressant, the antipsychotics, the this depression mania criteria, this eating disorder, the child psychiatry. These are the area. Hypochondriasis, yes, yeah, Manish. Hypochondriasis is basically patient having a preoccupation regarding the serious illness. Basically the normal physiological function or the benign symptom appear like a serious illness. Suppose patient having a weight loss, patient start thinking weight loss is a symptom of HIV, so I think I have HIV, so he will go and he will do the various tests for the HIV. Patient having an increase the bowel sound, and patient will think that the I think I have a colon cancer. So the minor benign symptom or the normal physiological function appear like a serious illness. This is a okay, this is a uh, yeah, hypochondriasis. Another name is illness anxiety disorder. Clear? Yeah. Okay, then best of luck from my bottom of heart. I hope you enjoyed the psychiatry and overall the yeah. Now clear, Manish? Okay, so best of luck, dear, and best of luck, other dear students. And please, uh, this our platform is they're covering all the subjects, all the you know amazing faculties you have in PW MedEd. So please go through it. It's a quick revision because before exam, this is I think Sigmund Freud psychosexual. As I mentioned, Manish, it's we have a oral phase, we have a anal phase, we have a the phallic, then we have a latent, and then we have a genital. Oral is 0 to 1.5, anal we have 1.5 to 3, then we have a phallic 3 to 5, then we have a 5 to 11 years the latent, and then we have a genital. Okay, oral phase there is a fixation. Just remember that there is a schizophrenia and the uh, the substance use disorder. Anal phase fixation, the OCD. The phallic phase is a the dissociative disorder. Okay, so this is about the psychosexual stages. So basically Freud told that when there is a smooth pass from one stage to another stage, there is no development of psychiatric disorder, but once there is a fixation, then there is a development of psychiatric disorder. Clear? Now I hope, yeah, more than that I can't go beyond because the session was only 6 to 8. Already we stressed it. So I think it is more than sufficient. Still you have some queries somewhere. Okay, I'm just leaving my number. If you have any query, just try to uh, I mentioned there or in our group. We have a yeah. So if there, if you please drop that message, I will try my best to give you answer as soon as possible. Clear? Okay, then best of luck and do well. Last 10-12 days, just 10-12 subjects, just revise them nicely, sleep well. Many students have a issue of night they study in, during daytime they sleep before exam. Believe me, you will not able to change this habit. So please start on time, eat well, sleep well. If you have a time, study well. Best of luck. Bye bye. See you after the exam. Please drop the MCQs so we can clear on we can discuss on 20th January. See you. We will discuss after the exam. We will start discussing on our platform this MCQ. So please be ready and give the MCQ as much as possible. Okay, bye bye. Take care. God bless you. Best of luck, dear.